Good morning. My name's Alan Weil. I'm Editor-in-Chief of Health Affairs. We're very pleased to release the March 2016 issue of Health Affairs. We're glad you're joining us today for a discussion of a group of papers in the issue. I should note that although we're focusing this morning on physicians, we have a broad array of content in the issue. Everything from a paper describing that workers who don't have paid sick leave go to work and forego needed care, to a paper that notes that earlier states that adopted medical marijuana programs with looser regulation have higher rates of enrollment than the later states that tend to have stricter enrollment criteria. So there's a lot in the issue that I hope will draw your attention and interest. But this morning we're going to focus on a group of papers that address the issue of physician practice and the evolving landscape of physician practice. I want to acknowledge the support of the Physicians Foundation for their support of the papers and the presentation today related to physicians. We have also a relatively new element of the journal, a data graphic, and it draws together data both from papers within the issue and other data sources, and the data graphic this month focuses on issues related to physician practice. I encourage you to take a look at that as well. The papers we're going to discuss this morning are a broad array. They cover a range of perspectives, and so rather than breaking it up into little pieces, we thought we would just go ahead and have presentations from all of our authors and get the range of issues out on the table. We're discussing, of course, matters of measuring quality, reporting quality, and then attempting to pay physicians for their role in promoting a more effective and more efficient healthcare system. We're including in today's session also this month's Narrative Matters, which takes a more personal look at the healthcare system, but also through the lens of the role of physicians. So I'm sure you're going to get a nice collection of perspectives and new empirical work related to the changing landscape of physician practice. And at this point, I'll go ahead and introduce all of our speakers, and we'll hear their presentations, and then we'll open it up for questions. So this morning, we're going to hear from Larry Casalino, the Livingston Farrand Professor in the Department of Healthcare Policy and Research at Weil Cornell Medical College. We'll hear from Sam Zuvekas, Senior Research Advisor in the Center for Financing, Access, and Cost Trends at the Agency for Healthcare Research and Quality. We'll hear from Elaine Burns, Honorary Clinical Lecturer on the Faculty of Medicine in the Department of Surgery and Cancer at Imperial College London. Phil Miller, Vice President of Communications for Merritt Hawkins and Staff Care, companies of AMN Healthcare, the largest healthcare staffing organization in the United States. And Carolyn Dickens, nurse practitioner at the University of Illinois Hospital and Health Sciences System, director of the Heart Failure Readmission Program, and a PhD candidate at the University of Illinois College of Nursing. So let me begin by turning it over to Larry. Come on up.
Oh.
Sorry, you have to do it.
Yes, thank you.
To get you up to your... Don't start his clock yet. Come on, right?
Yes, right.
We're not getting there. We go. All right. That's you, and I already took you too far.
Okay. So thanks for having me, Alan. So there's been a lot of anecdotal evidence and a couple of small studies purporting to show that there's a great burden on physician practices of dealing with external quality measurement. And we decided to do a national study and take a look at this. So with support from the Physicians Foundation and the Medical Group Management Association gave a lot of in-kind support, we did a national survey of leaders of practices of all sizes in family practice, general medicine, cardiology, orthopedics, and multi-specialty practices. And I'm just going to show you the results that we got. If I can move the slide here, let's see. Okay. So this slide is pretty simple. It shows that we found that per physician per week, practices spend about 15 hours, actually 15.1, on dealing with quality measures. And the slide shows the 5 or 6 categories of activity that we asked them about. You can see that by far the most time was spent on, the question was, the time spent on entering data into the EHR specifically for purposes of dealing with of quality measures. That was the most time, and the type of staff that spent the most time by far were medical assistants and licensed practical nurses, LPNs. Physicians on average spend about 2.6 hours per week. Okay, so it's 15.1 per physician per week from staff, and that includes all the physician time. And then 2.6 for individual physicians. 2.6 is about 9 patients a week, just for example. So this is not a trivial matter in terms of time. For primary care physicians, it was about, it's not shown on the slide, but it was about 3.9 hours, about 1.7 for cardiologists, and about 1.1 for orthopedists. So I'm a primary care physician, and I will note that, as usual, the most burden falls on primary care physicians. And in this case, most of the measures are, as people know, are directed at primary care physicians. If you just make calculations to translate the time spent by physicians and different types of staff to money, it comes out to about $40,000 per physician per year that practices spend on dealing with quality measures. For the specialties I mentioned, this comes out to about over $15 billion per year. But that shouldn't be taken as the figure for the entire United States, because obviously, if you added in all the specialties in the U.S., the figure would be presumably considerably bigger. I should note that you see here that, again, in terms of dollars, burden is higher on primary care practices. Now, and I'll just take this opportunity to note too. We described the limitations in the journal article, but this is crude, this study, right? And there are reasons to think that perhaps the figures are slightly overestimated, but I think they're probably in the ballpark. Arthur Cochrane, the epidemiologist for whom the Cochrane collaboration is named, once said that it's better to be roughly right than precisely wrong. And I'm pretty sure that we have this roughly right, I hope. This is a slightly busy slide. I'm not going to get into it in detail, but the point is to show, we asked the practice leaders about, are you spending more time now than you were 3 years ago on this, the practice? And 81% said yes, we're spending more time or much more time. And whereas only 27% said, we think these measures well represent the quality of care our practice provides. And about the same percentage said that we use our scores on these measures to direct our quality improvement efforts. Orthopedists were the outlier. They're the little bars there you can hardly see. They were much more likely even to say that these measures aren't useful for us. But that's not a surprise, and not just because they're orthopedists. It's also because I could make some orthopedist jokes, but I probably don't have time. And anyway, and then I'd have to make other jokes. But maybe in the question period. But there aren't very many orthopedic quality measures. And actually, we had a free text section. This was a web survey where people could type in any comments they wanted. And quite extraordinarily, I've never had this happen on a survey I've done before. 58% of the people typed in quite passionate comments. I'll show you a couple here if I can read them. So this is a family physician. Each small change made to a measure wastes extreme hours. We need to have these measures have some consistency. Otherwise, we're always training on reporting rather than improving care. So there's probably a couple of hundred measures, actually, that physician practices potentially have to deal with. And one thing that drives people crazy is that they overlap. So there may be a lot of diabetes measures that are almost the same, but not quite. And so one health plan will have one measure. It's almost the same as the CMS measure, not quite the same as the Aetna measure. Humana is a little different, and so on. This has been true for a long time. Ever since I started, since before I stopped practicing in 2000, it was true, and it's more true today. And then there were a lot of complaints about the EMR. So EMR systems don't have this built in. We've spent numerous hours creating structured data, et cetera. EMR vendors are changing a great deal to make us purchase the add-on piece that would help us complete this information. And I will add parenthetically that I just want to stress the fact that by far the most time from physicians and their staff went into entering data. This is a fault, I would say, both of the measures, but also of the EHRs, which are poorly equipped to both to input data and to get data out. And spend, I think it would not be too much to say that although EHRs are necessary and someday we'll have a world where they really help a lot, and they help some things now, it wouldn't probably be too strong to say that we're sacrificing a generation of physicians and staff to the problems with EHRs. I think that there's very strong evidence that EHRs are the main source of physician dissatisfaction, of early retirement. My best friend actually is a pediatrician, fantastic pediatrician. He retired early. He was getting overuse syndrome from clicking. I was talking recently to Chris Sinsky, who's a general internist in a large, very good practice in the Midwest. She said her nurses have told her recently, they have a new EHR from a major vendor. It takes a nurse 33 clicks to give a Medicare patient a flu shot, 33 clicks. She said, we're actually starting to tell patients, just go to the pharmacy and have your flu shot. We just don't have time to be doing 33 clicks for every flu shot we give. So obviously quality measurement is important, and we don't have to go into the reasons why. I think you can't really improve too easily what you don't measure. But clearly, we need better standardization of the measures. And for years, this seemed a hopeless goal. But just a few weeks ago, an announcement came out from the Core Quality Measures Collaborative, which is CMS, America's Health Plans, AHIP, and National Quality Forum, and then other organizations as well. But those are the three core. And they have agreed on a set of core measures, and they've agreed to try to, as measures evolve, to try to keep their measures standardized. And they have agreed, all of them, none of this is binding, to in fact gradually move toward making their measures these standard measures. So it's too soon to tell for sure how this will work out, but it is a very encouraging step that people have been calling for more than a decade. So then I mentioned with EHRs, we need EHRs that will make it easier to input data and easier to get it out. We need, the specialists would be the first to say this, I think, more specialty-specific measures, and that's being worked on. Specialty societies and others are trying to create meaningful measures for many specialties. And then I think also we need measures that physicians and patients will perceive as important, right? So it's not just looking for the keys under the lamppost, because that's what you can measure, but actually trying to develop measures for things that really matter. I think that physicians don't really realize what's going to happen with the SGR fix and MACRA and MIPS and the scoring of individual physician performance with all the many types of difficulties that brings, including statistical reliability and validity. I think when that starts to happen over the next year, there is going to be a lot of noise made, and it will make the issue here of time spent, I think, on quality measures even more important. And then I did mention, I didn't mention, but I'll mention just to close that I think the burden of dealing with quality measures and EHRs with quality measures is one of many factors that, for better or for worse, is pushing physicians to sell their practices to hospitals or other large entities. So thanks very much.
Just as we're bringing up our next speaker, we have folks in the back. Come on forward. Please clear dishes off your chairs and let people know, because there's plenty of room up here. There's no need to stand in the back, but let's just take a moment for the transition.
Well, thank you, and thank you all for coming. I'd first like to acknowledge and thank my co-author Joel Cohen for coming down early from our Rockville offices. Joel's not a morning person, so happy to have him here. I also need to give the standard agency disclaimer that the views expressed here today are my own and no official endorsement by the Agency for Healthcare Research and Quality or the Department of Health and Human Services is intended or should be inferred. So with that out of the way, this study is really a straightforward look at the trends in how insurers pay physicians, whether it's traditional capitation or traditional fee-for-service. in recent years have seen a renewed push towards alternatives for fee-for-service payment. For example, last year, Secretary Burwell announced a target of having 30% of Medicare payments tied to quality or value through alternative payment models by the end of 2016, and 50% of Medicare payments by the end of 2018. And the department happily announced last week that CMS had met its goal early, almost a year early this year. So this is not the first time we've talked about payment reform. Fee-for-service payment has long been recognized as having very poor incentives to provide efficient, high-quality care. In the 1980s and 1990s, peer capitation, in which a physician or other provider receives a fixed monthly payment per patient, regardless of the services provided, was widely touted as a mechanism for restraining costs. So in an earlier study we published 6 years ago in Health Affairs again, we found that capitation of physicians had largely fell out of favor by 2007, and that fee-for-service was increasingly dominant as a method of payment. So given all the alternatives to fee-for-service payment and the renewed interest in this area, we thought we'd take a look at more current trends in physician payment and update this earlier work. So our data come from the Medical Expenditure Panel Survey, which is a large-scale annual household survey that our agency runs. Joel and I have both worked on this survey, the MEPS, since before its launch in 1996. And we're interested in a single question that asks how physician practices were reimbursed by insurers, that is taken from a follow-back survey of physicians identified by MEPS participants as providing care to them or their family members. And specifically, we're looking at a question of whether the practice was reimbursed on a fee-for-service or capitated basis for each visit the household receives. So there are two important things, very important things to note about this specific measure. First is it's really a measure of pure or 100% capitation versus any form of fee-for-service payment. So it's quite possible that the practice is receiving additional incentives or possibly even penalties related to quality or outcomes, perhaps as part of an accountable care organization or some other alternative payment model. The second important thing to note is that it is a measure of how the practice is paid at the level of what the dollars come in from the insurer to the practice. But individual providers within the practice might be reimbursed in a variety of different ways, including by salary. So turning to the results, straightforward descriptive trends. If you look at the overall trend line in blue, you probably won't be able to see much beside the base picture, we see a substantial drop in the percent of visits covered under pure capitation arrangements from about 16% in the late 1990s to about half that rate by the mid-2000s, and then further declines to about 5% by 2013. So some of this declining capitation and the use of capitation is explained simply by declining HMO enrollment during the so-called managed care backlash. But that's not the whole story, because we also see sharp declines in the use of capitation even within HMO models. So private HMOs here are shown in the red dotted line, and Medicaid HMOs are shown here in the purple. You see a sharp decline. The other thing you can note from this graph is that even in the 1990s, the minority of physician visits within HMOs were covered by capitation arrangements. So capitation at the plan level is very different than capitation at the provider level, although these two concepts are frequently confused in policy discussions. So there are too many changes in the Medicare Advantage program and also how we ask about the Medicare Advantage in the Medical Expenditure Panel Survey to show you a trend line for Medicare HMOs. But in this next graph, we can look at the use of capitation in the 65-plus Medicare population as a whole, combining Medicare Advantage and traditional fee-for-service. This is shown here in purple, and again, you can see sharp declines from 1996 to 2013, despite the growth in the MA program over the same time period. And in fact, you can see in this graph of trends by insurer, remarkable convergence in the prevalence of capitation across all three major payers, Medicare, private, and Medicaid by 2013, are all converging to around 5 to 7% of all physician visits. Well, okay, there we go. So the last thing I want to show you is how the trends in payment look by region. So as you can see, there were big declines in the prevalence of capitation outside the West region. I don't doubt you'll be able to read the labels, but the red's the Northeast, the purple is Midwest, the blue is South, and then the green is the West. But there are big declines outside the West between 1996 and 2007, and then a further slight decline through 2013. But the drop was proportionally smaller in the West, again here in green, but still quite substantial. So California remains the big outlier across the country, where 26% of physician visits were still covered under capitation arrangements as of 2013. No big surprise there. So just to summarize the results of our descriptive study, so it's quite clear that despite its earlier promise as a solution to the problems of fee-for-service payment, capitation has failed to take hold, at least in its purest form. So the literature points to both problems with low payments and the unwillingness of providers to assume anything close to 100% of risk, the financial risk for providing care to their patients. And this experience offers something of a cautionary tale about current efforts to reform what is still an overwhelmingly fee-for-service system, in that there are limits to the amount of risk that providers are willing to assume. But at the same time, there are reasons to be hopeful, precisely because current reform initiatives tend to rely on a more balanced approach to risk sharing. That is, physicians don't assume 100% of the risk under most of these models. And they also provide more direct incentives for providing high-quality care by explicitly tying payments to measures of quality or outcomes. Thank you.
It's not easy.
No, I know.
Yeah.
It's a test. It's an agility test.
Right.
Hello, just get the slide in the right place. I'm Elaine Burns. I'm one of the clinical lecturers over from Imperial. First of all, I'd like to acknowledge my co-authors, Christopher Pettingill, Professors Athanasiou and Darcy, and also I'd like to thank Health Affairs for inviting me over from London. It's lovely to come here in the spring. So the background to this work, looking at the role of the public reporting of surgery-level outcome, was from the early 90s when, following an FOI request, cardiac surgeons in New York had their mortality data publicly reported. This then was disseminated through the US and has now led to dissemination through other surgical specialties. In the UK alone, up to 9 surgical specialties are mandated to publicly report their outcomes at a surgeon level. Why are we doing this? Well, there are many things that have been proposed that the mortality data will deliver. For example, improved transparency, the identification of outliers, performance monitoring, improved patient choice and referrer selection, and ultimately what we're all driving for is improvements in quality of care. We've done a narrative review of over 19 papers that looks at this particular area. I'm afraid, given the lack of time and the wealth of the data, I'm just going to give you a high-level summary of the different topics. So let's start off looking at the use of data in order to identify outliers and look at performance monitoring. The one significant factor in this area is sample size. I'll give you an example of my specialty. I'm a colorectal surgeon. On average, in the UK, a colorectal surgeon does between 20 and 30 cancer procedures a year. There's some work that was published in The Lancet which documents that in order for 60% power to look at a doubling from 5 to 10% of a mortality rate for my specialty, you would need about 97 procedures. So that's over 4 years worth of a surgeon's practice at 60% power. For a randomized control trial, we'd accept 80% power. That's over 197 procedures. Cardiac surgery is probably a better example of this. On average, cardiac surgeons will perform around 100 procedures a year. They've got 2% on average mortality from the UK. If you look at the data, you probably need about 130 procedures in order to get a 60% power. So what this is telling us is we need to be very specific about what data we're using for which purposes. In addition, we need to ensure that there's adequate risk adjustment, which will come on to a later factor in reducing the unintended consequences of such a measure. The next thing is, are we using this data to look at patient choice and to look at referrer selection? The data in this area is really just pertaining to cardiac surgery. There's very little looking at other specialties or other non-surgical areas. When we look at interview studies with cardiologists and cardiothoracic surgeons, one study showed that 22% of cardiologists discussed these scorecards or data with their patients, and 38% of them used to change referral practices. However, when we look also at the data, it's not clear from that. Some of the early studies show that there was a higher drive towards higher performing units, but no penalties in terms of the volume in lower performing surgeons. So the data around this is still unclear as to what patients want. And actually, there's no evidence looking at what the patients use this data for and what they want it for. So that's an area that we need to target in the future. What we're all interested today is improving quality. Now, there were 4 papers that looked at the impact of publicly reporting outcomes on the actual quality of care, which was measured by improvements in mortality. Unfortunately, all these studies were retrospective studies, and they weren't able to show a cause-effect. The 3 of the studies did show a risk reduction in terms of the expected mortality rates among the specialties. One smaller study, which perhaps is more uniform because there were no other changes within the practice, didn't show any differences in terms of the overall mortality. So there may be some improvement in quality driven by this, but we don't know because all the studies are retrospective and unable to demonstrate a cause and effect. We've been hearing about some of the other unintended consequences of quality measures, including the cost alone. But in this particular one, we wanted to pick out the things that are meaningful for us as surgeons. Does the introduction of surgeon-specific outcome data mean that we're not offering the patients the care that perhaps they would have got before? Some may argue that this is a better thing, that we're reducing the higher risk procedures. The studies that looked at the risk profile in the patients really overall said that anecdotally, in survey data, surgeons felt that they were changing the risk profile of their patients and that they weren't offering the higher risk patients surgery. However, when you actually looked at the data from New York, the studies from California and from Pennsylvania, and also from the UK data, there doesn't seem to be any differences in the risk profile of the patients before and after the introduction of the data. One particular area of interest to me is the impact of any health policy interventions on training. There's only one study that has looked at differences in surgical training before and after the introduction of these measures. This did suggest that there was less training for surgeons follow the introduction. In cardiac surgery, they weren't letting the trainees do these procedures. As a patient, you may argue that that's preferable. But in the future, it will have potentially an impact on future surgeons. So, from this review, what can we say? I think, reiterating the comments of our first speaker, each one has to be specialty specific. It may be for the smaller volume specialties that actually a hospital level is more appropriate than an individual surgeon level. For a specialty such as mine, actually, the technical impact of the patient in terms of what they're operating on is perhaps not the biggest factor in determining the outcome. So a lot of the allied healthcare services, it's the level of nursing, it's the level of critical care, the level of radiology. These are all within the control of a system within a hospital. So perhaps a hospital level outcome is more appropriate for certain surgical specialties. If we decide that we wish to continue with public reporting of surgeon level outcome, and there is a considerable appetite for it for good reason, then we need to look at specialty specific outcome. For those more infrequent procedures, then we need to look at more frequent outcome measures. Mortality is quite a rare event, thankfully, and statistically it's difficult to use it to control and pick up outliers in terms of surgical specialties. Irrespective of any of these, we really need to put a lot of thought and work into developing adequate risk adjustment. This is particularly important to avoid any unintended consequences of the data, as well as to allow meaningful comparisons between surgeons so that we're adequately identifying outliers and also able to compare surgeons directly. Thank you.
Good morning. Thank you for being here. And thanks to Health Affairs for the opportunity to present this morning. Again, my name is Phil Miller. I work with Merritt Hawkins. We are the largest physician search and consulting firm in the United States, conducting over 3,200 search assignments across the country. We also conduct research on behalf of third parties who retain us for that purpose. One of those is the Physicians Foundation, the sponsor of our event today. They are not-for-profit grant-making organization composed of some 20 medical societies. They asked us to conduct a survey to provide them with what you might call a state of the union of the medical profession. What are doctors thinking about their own profession? What are their practice patterns? How many patients do they see? And what do they plan to do in their practices in the next several years? We last conducted it in 2014. We're conducting the 2016 version as I speak. In 2014, we received 20,000 responses from physicians across the country. We also received 13,000 written responses from physicians, many of them legible. And they told us quite a bit about what doctors are thinking. And in my paper, which is a perspective piece, really an opinion, my opinion, I took off from the research Dr. Casalino conducted regarding the fact that doctors now spend over 2.5 hours a week documenting their quality measures. So what does this mean? What does this add up to? We may never know. There we go. Oh dear. What I'd say it adds up to is more of the same. I'll ask the time-honored question, is there a doctor in the house? Okay, I see a few hands. This is going to be old hat to you, but doctors, the medical profession itself is under strain. And basically it's under strain because doctors spend a lot of time, 4 years in college, 4 years in medical school, 3 to 7 years or more of additional training, learning how to be doctors. But when they become a doctor, they find that that's not what they're doing. They're entering data, they're dealing with forms, they're trying to get pre-authorization from some third-party insurance company to do something that they want to do for a patient and may be thwarted in that effort by someone who's not themselves a clinician. As a private business owner, they have to comply with all the regulations that anybody does who's an employer. They're practicing defensive medicine now, as Dr. Casalino indicated. They're having to document what they do in terms of quality, and they're being paid on subjective things that sometimes they have no control over. If your patient isn't very healthy and doesn't do what you tell them, it's kind of hard to track a doctor's performance and say, well, your quality is no good. So they're under considerable strain. I think essentially the main complaint you would probably hear from doctors if you talk to them is, I don't have autonomy over what I would like to do. I don't have autonomy over patient care. Third parties are dictating how I practice. And essentially, that erodes the patient-doctor relationship, which for most doctors, the great majority of doctors that I'm familiar with, that's the reason they got into medicine. It's for the power, the satisfaction of relating to that patient. And if you don't have that, what do you have for the work and the sacrifice that you have put in? So many doctors, I think, feel this, and our numbers sort of point that out. In our survey, we found that the majority of doctors view their profession, the medical profession, negatively. Over 50% are pessimistic about the future of their profession. 50% would not recommend medicine as a career to their children, which is particularly disheartening. A lot of doctors get into medicine because they're inspired by a parent or an uncle or an aunt. 29% would choose another profession if they had their education to do over. And other surveys besides ours report physician burnout and physician dissatisfaction, and I cite one of them here. Okay. But what does this mean? I'm sure a lot of you may not be entirely happy with your profession or have dissatisfaction. I think a lot of people, feel these feelings from time to time. I would argue with physicians it's particularly impactful because we all need a physician. They're the first person that we see coming into the world, often the last person we see going out. I think they're uniquely necessary among professions. And what we find is that a lot of doctors are voting with their feet. And as you can see here, we asked them what do they plan to do in the next 1 to 3 years. 18% said that they were going to cut back on hours to get some relief. Basically, I'm not going to do this as much. Over 9% said they plan to retire. We have close to 30% of doctors today are 60 years old or older. That's about 235,000 doctors. We're going to face a wave of physician retirements in the very near future. And our survey indicates that many of these doctors are planning to accelerate their retirement plans in response to what they see happening to their profession. If you note how many residents we train a year, about 28,000 coming out of residency, it doesn't equate to how many I think are going to be retiring in the near future. So we will have more water draining from the tub than we have coming into it. Some will switch to concierge medicine, direct pay medicine, where they drop most of their patients and just hang on to a few. Some will seek a non-clinical job, essentially take themselves out of patient care roles. Many will seek employment with the hospital. Some will work part-time. So when you add all these things up, each one of these career choices equates to a lack of access for everyone in this room, patients, because each one of these choices tends to inhibit a physician FTE that reduces the overall workforce, not necessarily the overall gross number of doctors that we have, but the overall net number. Just because of the way they are choosing to practice. As my friend, the late Richard Buzz Cooper, some of you may know of him, would say, it's not how many gross doctors you have, it's how they practice that determines access to physicians. So I myself personally have not seen a doctor in the last several years. I just go to a PA because I can't get in to see my doctor in the time frame that I want. The Association of American Medical Colleges projects that we're going to have up to 90,000 too few doctors by 2025. And I think this is one of the reasons. It's just the way that they practice. They're no longer getting out of residency, hanging up the shingle, working 85 hours a week and seeing all comers. They're working 9 to 5, a regular job, regular vacations. When their shift is over, it's time to go home. I think all of these trends raise the issue of who does the physician work for? The greatest change that we've seen in medical practice in the last 10 to 15 years is the growing number of physicians who have abandoned independent private practice to become employed by some larger entity, typically a hospital or a medical group. In our survey, we found that 35% of physicians identify as independent practice owners in 2014. That's down from close to 50% in 2012 and down from 62% when we first did the survey in 2008. Of the physicians that we recruit, 95% are going into an employed setting. They're going to be employed by a hospital, a medical group, an urgent care center, a federally qualified health center, or some other entity. Only 5% are taking truly independent practice positions, going into a solo practice or joining a partner and actually owning that practice. It's a complete qualitative difference, I think, in the practice paradigm. You can think of somebody who owns their own ice cream store, They hire the personnel. They're dedicated to hiring the right personnel. They'll see the last patient or the last customer who comes in. They'll work on the weekends. They'll do what they have to do to make that business work. And I just think you're seeing an evolution in the way physicians practice. The question becomes, who is the patient advocate? Traditionally, the doctor was. They would see you in their office. They would follow you to the hospital. Now you go to the hospital, you're going to see a hospitalist. So who is really looking out for the patient? Who has that patient's interest in heart? And when the physicians become employed, practically all doctors are employed, who do they answer to? They answer to the employer who is paying their salary. Instead of joining the AMA, perhaps they'll join the American Hospital Association. After all, their employers are hospitals. So again, just a qualitative difference, and I think if you speak to doctors, they would probably argue that the profession is evolving from what you might call a higher calling towards more a mere occupation, where they are employees like everybody else. They do their job and they go home. And unfortunately, my papers just raising these questions, it doesn't necessarily state the solution. I'm not entirely sure what it is, but I just think it's something to think about for policymakers and others to think about. How are we dictating how doctors practice? Are there things we can do to let doctors be doctors so that people will still be encouraged to come into the profession for the right reasons? Thank you.
Alan set this up as an agility test for us here.
Okay, thank you. I would like to thank Health Affairs for having us come speak today, and I need to thank and acknowledge my co-author who is here today, Stephen Brown. And if you're familiar with narrative affairs, you probably know that it's usually written by a single author, whereas our journal article today was written by 3 authors, which I think truly reflects the spirit of the care that we gave this gentleman I'll be talking to you about today. So our story was really written in response to the Hospital Readmissions Reduction Program, and this is a policy that penalizes hospitals who have excess in readmissions within 30 days. And when it was first developed and operationalized, it really targeted 4 conditions, heart failure being one of them. And really the assumption is that hospitals provide poor or inadequate care, and therefore there's this excess in readmissions. Well, the expectation would be then that hospitals would invest in resources and improvements in care coordination and discharge planning, and subsequently would see a decrease in readmissions. Well, there is policy and controversy that surrounds this policy, and this is because safety net hospitals were feared that would be penalized at a higher rate because they care for a disproportionate amount of patients who have low socioeconomic status. And low socioeconomic status has been related to poverty, poor education, and substance abuse and mental illness. So today, I hope to briefly highlight the limitations of this policy through a story about an interaction with a patient at our institution. So Mr. G is a gentleman who showed up at our hospital in August of 2013. His first admission to our emergency department, he came with fluid overload because of his heart failure. His past medical history was significant for his heart failure, diabetes, hypertension, and schizophrenia. But his social history was more complicated. He had substance abuse. He was recently released from prison 6 months prior to appearing at our hospital. He was homeless. He had a 5th grade education. He did have a supportive sister who did care for him, meaning that she cared for him emotionally. But he didn't have any insurance or an identification card to apply for insurance. So during this initial admission, we did the requisite heart failure interventions, and then on discharge, we gave him his appointment within 7 days. We gave him an hour's worth of educational provided. We had instructions given to him and his sister on how he could apply for a Medicaid, and then we had his prescriptions sent to a pharmacy near his sister where he said he was going to go stay after he was discharged. Well, after he was discharged, he went to his sister's place, and they fought within 4 hours, and he resumed to the streets, and he resumed his previous lifestyle. He did not pick up his prescriptions. He did not follow up with his appointment with us, and we were unable to contact him by phone because he did not have a phone. He was readmitted within 2 weeks at our institution in fluid overload from his heart failure. At this time, our super utilizer team that was targeted by Steve Brown and myself in charge of the readmission reduction program team met, and we really felt that he would benefit from a stable, secure housing. Well, we were unable to locate stable, secure housing, and then our second guess was that he would benefit from an inpatient substance abuse center. Well, we were unable to locate an inpatient substance abuse center because of his complicated prison history, medical history, and he didn't have insurance. So again, we followed the best practices at discharge. He said he was going to go stay with his sister, and he was discharged from our hospital. As you can guess, this cycle was repeated several more times where he would return to the streets, resume his previous lifestyle, not take his medications, and would be readmitted. His medical condition became steadily more serious, and his efforts by us to establish any sort of secure, stable living situation were unsuccessful. At one point, when Mr. G returned to our hospital at his 8th admission in fluid overload from his heart failure, the attending that was working on service with us was very frustrated and concerned about his medical care and his trajectory of his illness. So we were able to identify the only inpatient substance abuse center that would have a bed available, but the bed available would not be free within 2 weeks. So we kept Mr. G at our hospital, and the bed did not become available for a month. And we titrated his medications and treated him appropriately. At that point, we were able to transfer him with an ambulance to the inpatient substance abuse center. Unfortunately, he felt the rules and regulations at the substance abuse center were overly restrictive, and he left after only 7 days. At this point, he went to various different hospitals throughout the city of Chicago. Within our hospital, there's probably 5 or 6 institutions within a 1 to 2 mile radius. And over the next 2 to 3 months, he would contact us to tell us where he was, and we would fax and send reports to the other hospitals, to their nurse practitioners, physicians, residents, and social workers. We attempted to continue to try to coordinate his care because we did genuinely care what would happen to him. At one point, we were able to locate a transitional care center for him, but he left again. At another time, he was admitted to a hospital into their intensive care unit for 3 weeks. At that point, we again arranged a nursing home for him to be transferred, but he again left against medical advice after staying there for about 6 weeks. At this point, when he left this last time, his sister found out about it and went looking for him at the various streets where he would hang out. She found him at the street, and then took him to a local hospital, and where he died 4 days later from pneumonia. We felt a sense of personal loss given the amount of time we spent with Mr. G and his sister. But unfortunately, we have several Mr. Gs at our hospital throughout the years. This case highlights the paradox that we were dealing with. We had a problem to fix, but not the resources or the services to fix it. Not to mention a patient who resisted almost all of our attempts to help him. Hospital readmissions are known to be associated with certain socio-demographic factors, and I have a laundry list up here. Mr. G, unfortunately, had almost all of them, and even his social support would be somewhat questionable considering he kept resisting his sister's support. As we look in hindsight and think about policies and services that could have been available that would probably assisted Mr. G, there are several. A housing first approach, where individuals that are homeless are immediately placed in a stable living environment, and then their social needs and their substance abuse are addressed at that point. Reintroduction programs post-incarceration. Mr. G was released from prison without any resources, did not know how to apply for an identification card. If these resources would have been available to him, that would have assisted to him in applying for health insurance and social services, he probably would have seen a different trajectory of his health. A psychiatric crisis center, and of course, a shared electronic medical record. Again, our hospital is located in downtown Chicago, and we are located within several hospitals are nearby. The amount of time we spent faxing and receiving reports was unimaginable. So in summary, the HRRP is a well-intentioned policy that has helped standardize and improve care across the country. However, this complicated case highlights the limitations of this policy, because despite well-established programs, teams of healthcare professionals coordinating care, there are certain vulnerable patients that will utilize a disproportionate amount of resources. These vulnerable patient populations are concentrated at certain hospitals and institutions. So as new policies are developed and revised, policy measures need to recognize this unequal distribution of vulnerable patient populations. Future policies need to account for the social factors influencing readmissions when calculating readmission penalties. Thank you.
Well, as promised, we covered quite a range of topics. I'll make one last comment to those in the back that there are seats up here if you want to move forward for the question period. I'm going to start out, the questions I'm going to direct to individuals, but given the nature of the presentations, I have a feeling others of you may want to jump in. But let me just start, Larry. You obviously focused on the cost side. If we're trying to figure out policy, we want to think about the value of that, the tens of billions of dollars that physician practices are spending. Without getting into the math of it, which is not the point, I wonder if you could just talk about how you, as a physician and as someone who looked deeply into the question of how much we're spending, how would you think about what the value of that investment is so that we could actually figure out whether we had anything approaching a balance in the value relative to the cost?
Well, I think that it would be hard to really try to quantify the value, right? So I think I can only talk about it qualitatively. I think that I think it's important to distinguish between external measurement and internal measurement of quality, right? So there are medical groups in the country, quite a few of them, that do measure quality or take the scores that are given them by health plans or Medicare or whatever, and usually some combination of the two, and present those to their physicians internally. And sometimes they do it blinded, so you just see your score versus the average for everybody else. Some of the groups do it so everybody can see everybody else's score, right? And the medical directors of these groups all say the same thing. They say that all our physicians scream bloody murder. They all say my patients are sicker. They all say the data is wrong. And sometimes they're actually right. Some of the physicians may have sicker patients and the data may not be right, but they all get better, right? They all improve except for the really hard cases. So internally, I think that's a very useful tool because you do have the possibility of an individual physician of talking to your medical director and saying, Alan, look, 70% of my practice is HIV. Of course I prescribe brand name drugs. The fact that I have a poor generic prescribing rate doesn't mean anything. Internally, that kind of thing can be done. But if it's Medicare or United Healthcare or Aetna doing the measurements, it's a different story, right? There's no flexibility there. So I think that when quality measures are done by external entities, they really need to be pretty bulletproof, right? They need to be, as Elaine is saying, there need to be large enough numbers that the measures really mean something. And risk adjustment is a controversial issue. Risk adjustment for socioeconomic status is a controversial issue, right? Historically, there has been no adjustment for that. And actually, sometimes advocates for low-income groups will say, we don't want risk adjustment for that because we don't want hospitals and physicians being rewarded for giving our people worse care forever. So we could have a whole hour and a half on this, and I'm going on for too long. But I think when the trouble is that when people externally for CMS are mandated by Congress or from health plans by their boss to develop quality measures and incentive program, they do it, right? That's their job. And they don't want to hear that much about all the problems there can be. So we constantly have a system, I think, where the measures are lagging behind what they ought to be. And it does create cynicism and dissatisfaction and frustration and unfairness for physicians and hospitals. Not to say that we shouldn't do it, but these unintended consequences or problems with the measures aren't things that just should be kind of, oh yeah, well there's that. They should be front and center in considerations. But to answer your question, Al, which I realize I didn't do, I think, the potential value of measuring quality is very great. And there's no question that the move away from I'm a physician, leave me alone, nobody can measure the quality of what I do, just leave me alone, which was, for most of the years I was in practice, was the situation, which was fine with me as a physician, right? I think there's no going back to that, and I think so the general movement to let's see if we can measure things so we can figure out how to improve them is good, but we're not anywhere near where we need to be on the measurements.
Okay. Thank you. Thanks for both answering the question and also saying a lot of important things that were a lead into that, because that's the context. Sam, I realize your disclaimer at the beginning, you're not speaking for your agency, but I am struck as I look at the data that, as you pointed out, it's very possible, in fact, given what we publish in Health Affairs, likely that many of the fee-for-service payments that are being made do have some sort of a value component in them, and that's not what you're measuring. You're measuring full capitation. So I just wonder if conceptually we might find this division between fee-for-service and capitation, which used to represent really very different ways of thinking about payment, that in some sense that division is going away or is less relevant because the value component starts to capture some of the same goals that we have for capitation, or if you still really think of these as two completely separate types of payment.
Well, I think we can think about payment as a continuum these days. So you have the traditional capitation, which we were measuring at one extreme, and traditional fee-for-service, where there's no component linked to value or quality or outcomes measurement. All these alternative payment models is sort of a blend of some elements of capitation, but it's still largely within a fee-for-service sort of construct. Most of the stuff that we're talked about so far is more towards the traditional fee-for-service end than the capitation side. So I think that's where we stand today. Where we end up 10 years from now, it's not entirely clear.
Thank you. Elaine, you gave, I think, a very clear sense of the limitations of individual reporting, but you note at the outset that the movement began in New York and spread across other states in the US and then to the UK. And then Larry, just a moment ago, was talking about the internal uses of quality reporting. I'm wondering if you think, despite all of the limitations to individual surgical reporting, ultimately, even if the metrics themselves have limitations due to small numbers, if it unleashes positive efforts to improve quality and therefore could be seen as a good thing for maybe reasons distinct from the actual precision of the data.
I think what's happened, certainly in the UK, since in 2013 they mandated the introduction of mortality data, which for a lot of the specialties they introduced it's perhaps not the best measure, but it's starting somewhere. And the initial feeling amongst a lot of surgeons was exactly what you felt. Oh, the data's wrong. Oh, it's not fair. It's small numbers. But now we're just carrying out a questionnaire study at the moment, and generally what's coming back to us is actually surgeons know it's happening and they're happy for it to happen, because there is a feeling actually we don't have anything to hide. We're happy to be measured in terms of quality and what there is. And I think undoubtedly it will drive up quality. And I think the key element of it, whether it's for public reporting or for internal review, is to really make sure that we've got the key performance metrics correct. I'm sure it's the same in the US, but certainly what we're doing among specialties, one of the areas, inflammatory bowel disease, in my specialty, where it hasn't really traditionally been an area of focus, what we're doing as a specialty is now with patients, with all the stakeholders, using some sort of Delphi methodology to develop evidence-based key performance indicators that we can actually use and feel that we're happy to stand by and use them to drive up quality. So I think going forward, when we focus on the actual quality measures and there's a consensus of opinion that they are of value, I think that's actually when we can begin to move on and use those to meaningfully improve outcome for patients.
Thank you. Phil, you gave us a cautious view of what the future of physician practice would look like. Let's flip to the other side of the table and look at the patient's perspective in this. On the one hand, it certainly sounds like we'd be worried about access and the low morale, but some of the other presentations get into this notion of moving away from the physician is always right and getting feedback from some sort of a system that's analyzing data, feeding back data that leads to quality improvement. So I just wonder if your sense from your work and from the survey that you all administer, whether at the same time, some physicians are lamenting the future of medicine. Others are embracing a more team-based approach, not just to providing care, but also to understanding their quality in the context of how others are practicing.
I don't think that physicians object to quality-based reimbursement. I think they understand the value of it and the value of being judged. On quality measures, I think they object to the fact that they don't have control over what those measures are, or they feel like those measures are being dictated, or they feel they're not fair, they're not equitable, they're not realistic. I think that's the objection, not necessarily to the concept. I just think, overall, philosophically, in some policymaking quarters, there's an idea that physicians are a liability to be managed. There was a policymaking gentleman who said if 30% of American physicians were exported to a third world country, quality of care would improve in both places. It's just the idea that doctors are somehow need to be managed, that they don't bring value to the process, that I think they object to.
Thank you. Carolyn, the policy element of your Narrative Matters piece focused on the hospital reimbursement issue. Here we're really talking more at the clinical care level, and I just wonder if you could take a different perspective on the event that you describe in your piece and talk about how the existence of the measure and the existence of a performance measure at the hospital level made its way through the clinical practice and the interactions that you had, both with the patients you describe and with other patients.
Sure. Thank you. Prior to the HRRP, we had a heart failure program, but it didn't have this focus on the social factors. So when this initially came out, our response was to develop a program and where we really focused on this transitions of care, realizing that we were losing a lot of patients to the city, and then also hoping to standardize some procedures. So it really helped, develop and just help us just make the program a better piece. But again, per my colleagues, his development was this whole super utilizer piece where he worked in the emergency department and sees patients that overutilize, or I wouldn't even say overutilize, utilize the healthcare emergency department services. So that was a new piece, us working together, kind of identifying these patients and his patients, and he had much more experience with working with these reaching out to the community. So that was definitely a response to, on the clinical level, of us working together and as a response to this policy.
Yeah.
I mean, here is an example where an incentive measure did lead to positive changes in the efforts that hospitals make. The downside is that it probably will increase disparities between socioeconomically advantaged and disadvantaged patients, right? Because hospitals that have more of SES disadvantaged patients are more likely to get penalized, right? And they have less resources anyway, generally speaking. So basically, the rich providers get richer, the poor get poorer, and that will affect the rich and poor patients that they tend to disproportionately take care of. So one intended consequence of this measure and one unintended consequence, both of which are important, I think.
And in response, I'm a clinician, and I'm used to dealing with the core measures and making sure patients are on their ACE inhibitors and their beta blockers, and suddenly to be thrown into this piece of trying to coordinate care for homeless individuals who have been recently incarcerated really was something I wasn't trained for and had to kind of learn on my feet working with my colleagues. So it was definitely going from a real inpatient clinical practice to being almost a case manager, which again was something I was not trained for but learned on the job.
Great. We have time for engagement of you in the room, and I need you to, when you get a mic, first of all, to wait for a microphone and to introduce yourself when you ask a question. And the lights are bright, so I'm having a little trouble seeing, but let's go ahead.
Thank you. I'm Dr. Caroline Poplin. I'm a primary care physician. I'm one of those physicians who left to do something else. I still volunteer at the Arlington Free Clinic, where I have time with my patients, and it's much more satisfying. But do you think part of the problem is that the analysis of medicine as a business and the desire to use business management techniques to make it more efficient and productive? And the result is, instead of, if you tell physicians, if you demonstrate to physicians something is better, you persuade them. If they see that something works better and they get better results, they will do it. You don't have to tell them to do it. But instead, they're being managed from the top and given incentives and disincentives to do what management thinks is right. An MBA is a very valuable degree now in health policy. Do you think that's part of the problem?
Who wants to take that one on?
I do.
Okay.
Thank you, doctor. That sort of echoes what I've been saying. Again, when you consider in healthcare and everything else, you follow the money, and how doctors reimburse dictates their behavior. So we understood in the old days, okay, fee for service, the more you do, the more you get paid. That doesn't quite work. But we haven't figured out how to evolve from that. So everyone's looking for the Goldilocks zone. How do we have a compensation system that rewards productivity so doctors just don't get on a salary and sit there and twiddle their thumbs, and yet it gives them enough incentive on the quality side to actually shape their behaviors and change how they practice? And in our experience, I mean, we do this kind of on the street level, trying to create contracts that appropriately award doctors. People kind of just haven't figured out how to do it. Only about 20% of our contracts at this point have a quality-based incentive. So it's the conundrum that everyone's thinking about, but I think your overall point is valid. Medicine is an art, at least that's traditionally what it has been. If it goes to a business, what are the long-term consequences? Elaine, to my right here, told me before the event that doctors in England are going on strike tomorrow. So what is our long-term future with our physician workforce? Do they join unions to protect their wages like other employees? It's just it's the evolution of a workforce that has some disturbing implications, and I don't think anyone's really necessarily come up with a solution.
I'd like to address the top-down kind of command and control aspect of what you said. I mean, first of all, I think that we want to be careful. We could have this whole hour-and-a-half discussion as if all of medical care was about decisions that individual physicians or nurse practitioners or PAs make. And that's a very important part of medical care, maybe the most important part, but it's not the only part, right? There need to be, provider organizations really should have in place organized processes to systematically improve the care that their patients get. And these processes may not even involve physicians. So the best way to get high mammography rates, say, or colon cancer screening rates, is not to urge physicians to remember to ask their patients to do it and give them 50 cents every time one does. The best way is to reward their organizations for getting good rates. The organizations will put in place processes. The physicians don't even have to do it, right? So there is something too, and for small practices have trouble doing this, right? They don't necessarily have the resources. But I think that there really is a division in large organizations that employ physicians from ones, and I'm thinking now, let's just think about hospitals that employ physicians. There are ones where it's, as you say, So I was in a 9-physician private practice for 15 years in California, and for the last 5 years of my practice, we were owned by Stanford. And there were good things about that and bad. That could be a whole nother discussion. But I will say that they put a guy in charge of our practice who was a young physician who had never practiced medicine actually and was cold as ice. And his response when he told us something to do, and we asked him why, because it didn't make sense, was because I told you so, okay? That doesn't work, and to this day, I don't, well, I'll leave the personal vituperation. But there are hospitals across the country where there's a sincere effort to involve physicians at all levels in decisions about what goes on. And those places will do better, I think. The problem is we don't function in a perfect market, right? So if we did, you'd expect that the organizations that get it right and involve physicians in leadership and also give the rank and file a say would outcompete organizations that don't. But I'm not sure that's going to happen because the main source of competitive advantage in the U.S. isn't that. It's how big you can get and how much negotiating leverage you can get so you can get higher payment rates, right? And so we could have an outcome, worst case, where the organizations that succeed are not the ones where physicians are appropriately involved, but the ones that just get really big. And they can make much more money than the ones that aren't as big but involve their physicians.
Let's get some more questions. I see two folks back near the aisle here.
Hi, Erin Giovanetti from the National Committee for Quality Assurance. I have a two-part question. First, we have in developing quality measures, they almost always involve representation from the physician or clinician community in terms of specialty societies, but clearly the measures that are being developed are not of value to that community. And so I'm looking if the panelists have any suggestions or ideas about ways to better involve the clinician community in the process of developing quality measures so they have value, that they can actually be used for meaningful quality improvement. And then the second part is, as we move to these measures that have real value, a lot of what I hear is measures that reflect what an individual's preferences and needs are and whether or not a provider is helping an individual to meet those needs. And that involves data that's not being collected. And so in order to get to those quality measures, we need that data to be collected. And then we go around in the circle of, well, there's already a documentation burden and providers spend too much time documenting quality measures. So if you have any thoughts on how we get to a point where we have these meaningful measures that involve data that's not currently being collected, I'd be interested.
I could respond to the participants. Of course, I think with, for example, the readmissions program and the people that are on the ground faxing and receiving reports, I think, not involving all healthcare clinicians, of course, nurse practitioners, social workers, and the individuals that are actually working with the patients, in addition to the physicians, in the day-to-day basis.
I think you're right that it would be a mistake to think that physicians are not involved in the creation of policy measures. A lot of them are physicians who you wouldn't call rank and file necessarily, right? They're policy entrepreneurs. But still, specialty societies, the AMA as well, are now involved by and large in helping to create quality measures. So I think it's not like there are these kind of evil people imposing things on physicians necessarily. To your broader question, how can we get, and the reason we don't have better measures, not because people are stupid or evil, I think it's because it's actually very difficult to do. But clearly there are major areas that aren't covered. So diagnosis would be the obvious one, right? And I think the thing that gets a physician most respect among other physicians, and this is to some extent true even of surgeons, is to be a good diagnostician, right? And we don't measure that at all because it's very difficult to measure. And I think it's very likely, I actually had a piece on this in New England Journal some years ago, that based on personal experience, attention to the more trivial quality measures could very well decrease the rate of diagnostic accuracy, and we would never know that, but that would be a net loss, I would say. I will say that I think, I'll just give a pitch here for one quality measure that I think is global and that can get at a lot of aspects of quality without increasing the burden of physicians. There are some places now, University of Utah is one, there are others, that are basically every time a patient gets seen, they give them a chance in the office or when they get home to complete an online brief survey. And some of it's just your usual caps, check the box, 1 to 5 score, whatever, which is fine. But they also give them a chance to put in some narrative comments. And since it's a computer, the people can type it in without too much effort. So they're collecting now 40, 50, 60 narrative reviews of per year per physician, right? Just kind of like TripAdvisor, where you can read restaurant reviews or hospital reviews. You go to Yelp and you see 3 reviews of my performance, I'm not going to like that very much. But if there's 50 or 60, I may also not like it, but it's probably accurate, I mean, if I read 50, if I'm reading hotel reviews, you can see ones that are just kind of crocs, right? And people, the service staff didn't bow down to them, and so they hate the place, and you can discount those. But by and large, you can get a pretty good idea overall of the restaurant or the hotel. I think you can do that with physicians as well, and that will get at things like diagnosis, because patients will know, for example, often if they were misdiagnosed. University of Utah, the key thing here is they're making this public. You can go to the University of Utah Medical Center website and look up any of their physicians and read these reviews, right? And they've noticed that physicians' scores, their quantitative scores, have gotten a lot better since they've started doing this. It's not just that you have a score to improve on, but you actually have comments to improve on, right? So you kind of know what patients are experiencing and what they say is wrong. When I teach and I get evaluations, usually they're pretty good, but there's often a couple that are pretty negative, right? And when I first read them, I think, oh, how dare they, they're crazy, so on and so forth. But if I go back to it a few days later, I say, okay, they may be a little crazy, but there's actually probably something to what they said, and I can work on improving that. I think it'll be the same for physicians. So I would really push that, and that adds to the burden of physicians not at all, although someone has to do these surveys and collect them, and there's a cost to that.
Let's see if we can get a couple more questions. Yes.
Hi, my name is Ash Davison. I'm a physician originally trained in internal medicine and boarded in clinical informatics as well. We have a course coming up in a few weeks for first-year medical students at Hopkins. Every year we do an informatics course. It's over 3 days. It's not something that I even had when I was a first-year medical student. I'm sure many of you didn't either. I'd love 1 or 2 suggestions from some of you in a short period of time like that, if you had to impress upon first-year medical students and expose them to some of these issues that they'll be dealing with, how you'd perhaps find a balance that we struggle with between making things too abstract about quality measures or systems-based care versus making things too depressing for them and wanting them to all go and create their own startup. So would love some guidance from some of you.
I'd like to just say that I was very struck by Carolyn's the way that she presented her scenario, and I think that's such a rich background in order to take everything for them from the impact of a particular policy to ways in which they can track the patient's care, come up with better interaction between different hospitals, because the clear issues that you had there. And that, personally, when I was a medical student, that was the thing that most interests me. Makes it the least abstract as possible and just base it around a complex patient's care, because everyone can understand that, and then take the issues on from that, I think, is an essential way of doing it.
Yes.
Hi, I'm Kathleen Sheen with Health Policy Experts. I just wanted to ask you, a lot of medical societies are doing registries, and many of them are used for internal reporting assistance, but there's also a possibility that they can be used by federal and state governments. So I'm just curious as to what you all think about registries, what the power of them is, what are some of the important components that they need to have to be able to do the right job.
I'll answer this one as well. Surgical registries are quite ubiquitous and have been increasing within the specialty, both in the US and in the UK. In the UK, they've been used really in 2 different ways. The sort of national databases such as the National Vascular Society, the Bariatric Society, are now the data that's been mandated to be publicly reported, and each physician has to submit their data to them. And they're used for performance monitoring, but they also have a much more interesting use in terms of tracking new technologies and looking at the introduction of new surgical specialties. We're sort of relaunching a new one looking at particular type of surgery for patients with inflammatory bowel disease, and we're using that currently to look at activity and look at the types of different surgeries that are going on nationally. And I think the role of the registries, although they're reasonably expensive and have time in terms of putting data, can add something that all the other routinely collected data are missing because of the level of clinical data. And I think for the right purpose, they play an essential role.
Take two more right here, and that's probably going to bring us to the end.
Thank you. My name is Lee Rucker, independent policy consultant. My firm is Enhanced Value. The Narrative Matters piece about Mr. G is a perfect case study, if you will, for the CMS Innovation Center Accountable Health Communities grant opportunity that fortunately last week they just extended the application deadline into May, which a huge sigh of relief I'm sure was heard around the country. It sounds like, I mean, everything that you were doing is certainly right in line with the opportunity within this Accountable Health Communities grant, for which there was a great health affairs blog a week or so ago, that you've been on your own and with your immediate partners within the hospital trying to build the connective tissue to enable the social determinants of health to help your patients. And so my question is, I would hope that you are considering this Accountable Health Communities opportunity, because it's specifically to address this so that the practitioners can get back to practicing medicine, but you have the automatic connective tissue with the other social organizations throughout your community.
Sure.
Thank you.
Thank you. I would have to, I think my colleague could address that, whether we had applied for that or not. I mean, I'd heard, yeah, we had applied for that, our institution had. So, but thank you.
Very good.
Hi, I'm Laura Gordon with Edelman, and I run our health practice there. And my question is, since I was a cub reporter probably 25 years ago, writing about the fee-for-service, bemoaning it, especially primary care physicians saying it doesn't reward the most important thing we do, which is consult with patients. It rewards doing things, services. And yet here we are today, and Mr. Zuvekas presented the fact that it's still fee-for-service is dominant. So I guess my question is, with all the smart people looking at and fee-for-service and talking about how it drives up costs and doesn't reward what physicians value, how have we not solved that, and why is it still the dominant way of payment?
I think it has the advantage of administrative simplicity and its familiarity in the long term. It's just institutionalized in how billing systems are set up. And we haven't figured out a way to incentivize or to create incentives in a way that is administratively simple for insurers as well as providers in a way that that works.
I think it's human nature. Everybody else in the world gets paid based on the volume of what they do. A plumber, the more pipes he replaces, the more he gets paid. A lawyer, the more hours he bills, the more he gets paid. It's just something that everybody can understand, and I think there's at least a certain inherent fairness to it. The harder you work, the more you get paid.
And it has automatic risk adjustment built in a sense, right? If you leave out quality measures, if patients are sicker and they need more services, you're paid fee for service, you're getting paid for them. You're paid capitation, you're not. So it avoids some of that kind of question as well.
Well, as we wrap up, I'll just say, as we think about this issue of payment and reporting and the costs associated with doing so, anytime you roll out a measure, a new payment model, it's easy to offer criticism, but you want that criticism to be empirical. And I think what we've done today is provided some data about where we are, not just sort of grousing. It's also striking to me that for each of the failings that were noted by authors, there's also some of the intended effect that's directionally exactly where we want to go. So clinicians are expanding their view of medicine and building relationships even prior to support from the federal government to do so. Organizations are investing in improvement internally. So we get a lot of things going in the right direction. The problem is there are unintended consequences and there's imperfection in the signals that we're sending to the healthcare sector. So ultimately to the policy community, which is who we try to speak to, and in some respects this brings in the final topic we discussed, is from a policymaker's question is, do you wait to figure out how to do this better and hammer out more of the imperfections, or do you implement knowing that it's imperfect and then hope that once it's out there, there's a lot of incentive to and motivation to improve? And if you do if you take the course of going ahead and implementing something that's by definition imperfect, how do you harness the kind of information that you would need so that the improvement actually occurs, so that you move from the critique of the model to actually refining the model? I hope that the papers and the discussion we had today contributed in all of these respects, both to understanding the critique of the approach and the evidence behind it, understanding the consequences of the approach, and also providing some evidence so that policymakers can improve, which after all at the end is what we hope for. So with that, let me just again thank the Physicians Foundation, thank our panelists, remind you that we will in April be releasing an issue on consumers' use of evidence, which ties into some of the topics that were discussed. Again, thank you for joining us.